Saturday afternoon. We meet up once a month. My name is Dr. Wong Pik Wee. I'm a consultant cardiologist. And today I have a very important guest. She's Professor Tan Maw Pin. I've known her for last maybe 5 to 6 years. She's a professor of geriatric medicine in University Malaya. And she has spent many years overseas for training, and especially in United Kingdom. And if you look at her CV, it's a very long 3 pages CV. But I want to highlight that she has about 42 research paper in the peer review journals. And recently, I think about a few years ago, since 2019, she has one of the big grant, about 6 million, to study the transformation of the cognitive frailty to later life self-sufficiency study was given by the Ministry of Education. So with that introduction, I want to invite Prof Tan to the floor, and she's going to talk about falls and prevention. So hopefully she can teach us how to help our elderly patient to prevent them from falling. So with that, I'll pass the floor to you, Prof Tan.
Thanks very much, Dr. Wong, for organizing today's platform. And I would never resist the chance to actually talk to any audience about falls. So I have gathered that many of you actually work in the community. So I try and tailor this talk to really try and, the talk isn't actually to teach people how to manage falls, because management in the falls in the community is a multi-agency thing. So as a GP, a family physician in a clinic cannot do it on their own. So really, this is to actually convince you that there's enough evidence out there for you to start taking action. And this call for a sea change in the way we practice medicine in the community. So here we go. Okay, so falls, how common are they? Yeah, everyone knows that older people fall, but I don't think anybody really fathom how big falls is amongst older people. And this is big. Okay, so this is actually published evidence from the Malaysian Elders Longitudinal Research, which is actually a study involving 1,700 individuals aged 55 years and over, living around in 3 parliamentary constituencies around the University of Malaya. So we asked these people, have you fallen in the past year? And overall, 1 in 4 of them said yes. And there is an ethnic difference. For some reason, the ethnic Indians are more likely to fall compared to the ethnic Malays. Nobody quite knows why the ethnic Indians have a propensity to throw themselves on the floor, and neither does anybody know why Malays are less likely to fall, apart from perhaps they have a floor culture, so it's difficult to fall if you're on the floor in the first place. So this is another separate study that was done by Professor Philip Poi. He started it and I finished it because I like finishing things. And he started this in 2002. He collected information from 200 consecutive fallers attending the accident and emergency department. Then he asked them about their activities of daily living. And then he called them up 6 months later and found out about whether the activities of daily living have changed. And indeed, as you can see, initially, very few of them would have had bowel incontinence, but after 1 index fall presenting to the emergency department, this had increased to 15%. And let's look at stairs. Only about a third of them could manage stairs before they fell, but 6 months later, only half of them could manage stairs. So falls lead to increased dependency, no doubt about that. And after 1 index, this is after 1 index fall, 6 months after 1 index falls, presenting to the accident and emergency. How about death? Well, we always talk about cancer being deadly, but nobody ever thinks about falls being deadly. But falls is deadly, and falls nowadays is perhaps more deadly than cancer because cancer has turned into a chronic disease. So within a year of having presented to the emergency department with a fall, the same group of people that Professor Philip interviewed in 2002 were no longer 20% were no longer alive after 1 year, and only 20% were still alive after 10 years. Now that is pretty deadly if you ask me. So why do these people fall? So we followed that on with a randomized controlled trial looking at a multifactorial intervention in fallers presenting to the emergency department and also primary care. So we managed to recruit 264 of those who have had 2 or more falls in the past year or 1 injurious fall. And 4 out of 5 of them were on what we call false risk increasing drugs. So there's a list of drugs such as cardiovascular drugs, vasoactive drugs, cardioactive drugs, neuroactive drugs that actually increase the risk of falls in older people. This is readily available. Just Google Fritz on the internet and you'll get it. So 4 out of 5 of them were on these Fritz. And normally when we talk about falls, the automatic referral is to the physiotherapy. Well, guess what? Only 3 out of 5 of them actually had a gait and balance issue. So if you just refer to the physiotherapist, 2 out of 5 of them will not actually be appropriately referred. And surprisingly, the prevalence of orthostatic hypotension in this group is just as high as gait and balance problems. So referring to the physio is not enough. You need to measure their lying and standing blood pressure and see if, and most of the time, if there's a drop, most of the time, in fact, there will be a drop, and most of the time the drop will be due to a false risk increasing drug. Okay, and then 1/3 of them will have had home hazards leading to falls. A quarter of them will have visual impairment, and a quarter of them also have vasovagal syncope. Not all of them will actually say they fainted because by the virtue of them being unconscious, they would not know that they are unconscious. So we call this amnesia for loss of consciousness, and we can even demonstrate this in young people who have fainted. Not all of them would have remembered fainting. So it's very important to take the history properly. If they can't remember how they fell and can't give you a very accurate account of what happened, then you need to think about conditions such as vasovagal syncope and orthostatic hypotension and actually do a test for it. I'll show you the test later. And then Malaysia is Malaysia law. So they all have bald Bata shoes, and I was mortified when Mahathir actually advertised for Bata slippers after he won the last election. And quite a few of them have osteoarthritis, and the list goes on. If you added all this together, it comes out to several 100%, because the whole key of showing this graph is that falls is a multifactorial problem. You can't just adjust the medication, expect it to go away. In fact, you're going to disappoint yourself, and then you're going to give up looking after falls because you don't think that falls are preventable. Okay, so this is the next thing. Don't just play with the blood pressure medications. So 70% of Malaysians age 60 years and over actually have hypertension. So more older people have hypertension than those who do not. So a lot of them are on antihypertensive drugs. But just because they fell doesn't mean that it's the drugs that caused it. It's the blood pressure drugs that caused it. And this is Anam's work, and she actually found that no matter what we did, we couldn't show that any single antihypertensive particularly led to a fall. So it doesn't mean that not antihypertensives are not associated with falls. No, it doesn't mean that. But it just means that you can't just attribute the fall to the antihypertensives. You need to really prove that there is a presence of orthostatic hypotension, and then stop that potentially offending agent, and then prove that the orthostatic hypotension has gone away, and before you just stop the antihypertensive, because they might need the antihypertensive, because and if stopping the antihypertensive will actually put them at risk of strokes. So how about false risk increasing drugs? Yeah, so yes, so what nowadays polypharmacy is ubiquitous. So this is Anam's work again. Basically, she looked at polypharmacy, and yes, when you look at polypharmacy on its own, there's no association with falls. So don't just keep playing with the medications. You need to isolate the Fritz. So if that's falls was associated with 2 or more false risk increasing drugs. And once you take away the false risk increasing drugs, polypharmacy was no longer associated with falls. So you need to know what you're doing. Don't just simply stop medications. They might need it. Okay, and this is really the big thing, the big thing about falls nowadays, or about management of medications in older people, anticholinergics. So anticholinergic activity appears in a lot of drugs that we don't know about, that we don't know it exists in. So we all know about the antipsychotics, such as such as chlorpromazine, and the really old antipsychotics, and also the really old antidepressants such as amitriptyline. We all know about the anticholinergics. So when Anam looked at anticholinergics in over 400 fall lists and controls, she found that yes, anticholinergic activity, even on drugs with very, very mild activity, actually led to increased risk of falls. And these drugs include, atenolol, um, colchicine, which is a drug we use to treat gout, furosemide, um, nifedipine. So these are very common drugs that you use in a GP practice, and they actually potentially increase the risk of falls because of the anticholinergic activity. So, and as this is just a proof of point, when we looked at fallers and non-fallers, we stand them up, the systolic blood pressure drop is much higher amongst fallers. So orthostatic hypotension is actually a very prominent and underdiagnosed risk factor because we don't test. We do blood pressure sitting down. We never do blood pressure standing. I don't know why. Someone started it and we just continue without asking. Yeah. So, and we did ask whether we could simplify this, because if you ask a family physician, are they able to lie the patient down for at least 5 minutes, preferably 10 minutes, then stand them up for 3 minutes and do the blood pressure lying down first, and then at 1 minute, 2 minutes, and 3 minutes of standing. A lot of GPs says they haven't got the time. Yeah, it takes too long. 15 minutes for something like this is too long. So can we just get the patient stand up and do the blood pressure? Well, yes, we seem to be able to find that standing blood pressure might just be good enough to actually detect low blood pressure with standing. So maybe just do the blood pressure standing if you can't do anything else. So the other thing is people never think of this, your heart. Now, not so commonly does a heart problem lead to a fall, but when it does, it's deadly. So we actually advocate that every single faller has an ECG. And this is Izati's work. And he showed that fallers actually have significantly longer PR intervals and significantly longer QT intervals. So we actually literally put our fallers on 2-week-long ambulatory blood pressure monitoring. And if we are very, very highly suspicious of a cardiac arrhythmia, we actually ask our cardiologist to implant implantable loop recorder. Yes, I know it sounds extreme, but a hip fracture is pretty expensive too, you know. Yeah, so if you have high index of suspicions, go straight to the thing that's going to give you a diagnosis, because it's no play, not a playing matter. People, this is deadly. So we always have a high index suspicion, and you start with an ECG. If the ECG is abnormal, it's cardiac until proven otherwise. Yeah, and we see a lot of heart failure fallers, and really you're concerned about malignant arrhythmias such as VTs, etc. Sometimes we don't look, but we just tell the patients, we think that your heart is not really doing very well and you're falling because of your heart. Yeah, can you please get your affairs in order, etc. That might be what we do, because they're too frail, really, and a defibrillator is not really what they would want. So when you go down that route, you need to consider whether they're suitable for an implantable cardiac defibrillator. And some people should have it. I wouldn't say not all of them are not suitable. Okay, so this is the results of a randomized controlled trial looking at our patients with falls. And basically, patients with two or more falls or one injurious falls randomized to individually tailored 6-component intervention, which includes otago exercises, home fast home hazards assessment, cardiovascular assessment, so looking for orthostatic hypotension, vasovagal syncope, or carotid sinus hypersensitivity. Yeah, I won't go into that, those kind of things, but that one you need to refer. And then vision assessment. They have early cataract operations, medications review, and falls education. And then the control arm, just they could have any of these interventions, but that would be under the conventional management and health advice group. And then we looked for false recurrence using a monthly diaries, and we kind of topped it up with the follow-up visit information, because not all of them, some of them lost their diaries, not all of them returned their diaries. Yeah. So yeah, a bit disappointing. There was no reduction in falls with over 1 year follow-up despite this very extensive intervention. But when we looked at the what do you call that, muscle strength and their balance, then we saw that the intervention group had significant improvement in the gait and balance measured with the time up and go test and the functional reach. And this hand grip thing is very interesting. We didn't do Otago exercise, is a lower limb girdle exercise. So we didn't do any upper limb exercises. But when what we found was a group that we intervened, the muscle strength stayed the same. So hand grip is a muscle strength measure. But the group that we didn't intervene, the muscle strength went downhill. So based on this, we kind of got an increased understanding that when you actually intervene on someone with a fall, you're not necessarily looking at preventing falls, but falls is actually a sentinel event of something actually bad going to happen to your patient if you don't do something. So you still need to intervene, and measuring falls outcomes might not be the right thing to measure. You actually need to intervene to stop this person getting frailer and dying prematurely. Okay, so there's a lot of evidence out there now, but when you ask the average family practitioner out there whether do they actually do anything with falls, most of them say no. Yeah, some of them says that they have other priorities. Blood pressure management is far more important, or the patient comes in for something else, not falls, so they prioritize the other person. The systems issue, yeah, there's nothing out there to help me manage it, and I can't do it on my own, so I don't do it. I lack the skills and training to manage falls. The caregivers are not cooperative, they're not interested, and I have issues actually talking to the patient about falls. So those are the healthcare professional issues. Then the patients, they think that falls part of old age. They don't think it's something serious, so they trivialize the falls. They can't access tertiary centers like hospitals to actually go for falls. And then when we go to falls interventions, and then when we ask them whether we can go to the house to do modifications, they don't want anything changed in their houses. And most of them, after a fall, would actually attend a traditional healer rather than a doctor. Okay, so not easy for us to persuade people. Okay, so only 46% of our family practitioners actually asked routinely about falls, and 70% were not familiar with guidelines. Only 70% actually reviewed blood pressure medications, and only 10% actually screened for gait and balance using a tuck test. The knowledge is not bad. Most of them know that gait and balance is associated with falls. They know that footwear is associated with falls. And then most of them would just tell the family, be careful, don't let them fall again. So that's probably the management of choice at the moment for falls prevention. So most of the time they say no time, other competing demands, no training, no educational material. Patients have too many problems. They have too many patients. No one to delegate the work to. Patient don't want to do anything. Payments too low. Some people are quite honest, and no incentive, so they're about the same thing. Okay. So we started the falls and syncope service to overcome the systems issue. We started the falls and syncope service in UMMC in 2015. Sorry, it's not 200 patients today, it's 2,000 patients today. And we see patients through ED, primary care, outpatients, orthopedics, medical wards, and I get referrals from from all the states in Malaysia, and sometimes from overseas if they have if they get off the plane and they fall in after fainting on the plane and they go and see a doctor in the UK, the UK doctor will refer to me, and it's happened in the US as well and Australia. So what we found was that there was an overlap between syncope, dizziness, and falls based on the data of 200 patients actually analyzed by Sin Yin, who actually spent some time with me. She's now a doctor in Sabah, a very good girl. So basically, that's why geriatricians end up managing falls, because of the overlap between these conditions. Okay, so this is actually some work done by Rosalind using our falls registry. So she actually applied in a tool called the Start Stop tool, which looks at potentially inappropriate prescribing. And 50, 56% of our drugs that this is 56% of drugs, it's not 50% of people, were actually that was found to be inappropriate in our false setting, was of course false risk increasing drugs, but anticholinergics, analgesics, endocrine drugs, urogenital drugs. So there's a lot of inappropriate prescribing going on in patients who attend our falls clinic. We've also worked with the Malaysian Society of Geriatric Medicine, as well as the Malaysian Orthopedic Society, the Endocrine Society, to come up with a position statement in 2020, which we hope will actually help family physicians look at falls prevention in our setting, and also drive, if you're in a hospital, drive your hospital policy when it comes to falls prevention. And to make it more accessible, we've also commercialized our service. And this is our center at the Section 19 in Petaling Jaya, where we can do falls assessments. It's not a medical input, because we just do the falls risk assessment there, and then based on that, actually refer to the relevant doctor or physiotherapist or occupational therapist. We've also managed to secure funding from the Malaysian Convention Bureau to hold the first World Congress on Falls and Postural Stability in Kuala Lumpur in 2019. And that actually then brought together a lot of people, and that led to the publication of the World Guidelines for Falls Prevention for Older Adults. This was published in the second half of last year. So basically, this world guidelines, I'll share a little bit with you in whatever time we've got left. Actually involved 93 world experts that voted for the recommendations from 40 countries, 36 international societies, and we had 25 steering committees and 12 working groups. It's a huge, huge project. So these were our working groups, and I was given the privilege of actually leading the developing country working group, which was working group 9. Okay. And so this is what we did. We had this overall steering committee. We had the working groups working together, and then we came up with the preliminary recommendations, and then we sent it out for voting, and then revised recommendations, and then voted again, and then the final recommendations and guidelines were developed. So the full report is actually also downloadable from the Age and Aging website alongside the paper. So the paper is free for view, despite Age and Aging being a paid journal. Okay, so the key points is that the falls and related injuries are increasing because of population aging, and therefore prevention and management is a global challenge. So, so the main thing we want people to do, people in this platform to do, is to help us with opportunistic case finding, because they may not actually tell you that they've fallen. And then the multifactorial intervention or multi-domain interventions tailored to individual risk factors are effective. So it's actually multifactorial, not just changing the medications or sending them to a physio. And you need to engage the older individual's beliefs, attitudes, and priorities about falls. And then we will have to modify the recommendations to meet the needs of low resource settings, such as lower middle income countries. But there are many low resource settings even in developed countries. Okay, so everyone will know about gait and balance. So I'll just go through the recommendations, not all of them, but the ones that are relevant to caring for the older person in the community in particular. Okay, so they actually recommend using gait speed for predicting falls risks. So they can have very fancy machines to measure gait speed, or you can just use a stopwatch and a walkway, and then measure how fast someone can walk between 2 points and then calculate the gait speed. Or in Malaysia, we actually prefer you to use the timed up and go test, which is actually getting the person to get up from a chair, walk 3 meters, turn around and sit back down again. And the time they actually take to do that, it should be less than 13.5 seconds. So the cutoff of 30.5 seconds is what we use in the University of Malaya Medical Center to actually say that they are at an increased risk of falls. And then so we do also recommend that gait and balance should be assessed as part of the risk assessment. So that's using the time up and go tests for Malaysia. Polypharmacy. Okay, so we all know that fritz now increase the risk of falls. So please ask the patient whether they've fallen or not before starting them on a frit. And then, so you should hopefully use a validated structured screening assessment tool to identify FRITS. So there are tools available off the internet for FRITS. There's also this tool called Stop Falls, which incorporate FRITS into the Stop Start tool that also that looks at inappropriate prescribing. And then if you find a FRIT, please consider medication review and appropriate deprescribing. And for long-term care, if you look after patients with care home, all the fall prevention strategy should also include rational deprescribing. Cardiovascular risk factors, my favorite. Okay, so as a multifactorial risk assessment, you should actually take a good cardiac history, listen to their heart, looking for murmurs, do a lying and standing blood pressure and a 12-lead ECG. So if someone comes to see you in clinic with a fall, and they've had 2 or more falls, or they don't have any gait and balance impairment, then you should consider this, okay? And then if they don't have any abnormalities in any of the above, then you don't need to do anything else. You're happy unless someone says that they have unexplained falls, in which case you should suspect syncope. And then if you suspect syncope, then there are syncope guidelines out there to actually, and I'm not the best person today to actually talk to you about evaluation of syncope. Okay, and then we should always recommend that management of OH, orthostatic hypotension, as part of our multi-domain intervention. And if we we should always incorporate cardiovascular interventions during the assessment for risk as the same as syncope, so that we can actually synchronize with the syncope guidelines. So if you suspect syncope, if you refer to someone who actually knows how to manage syncope. Okay, so exercise. Yeah, so the exercise, of course, is an intervention. So what sort of exercises? So if someone with gait and balance problems, you should have exercise 3 or more times a week. Someone who this one is for someone who has never fallen. So if you have never fallen, you should still exercise at least 3 sessions per week or more, at least, and your intensity should go up. Okay, and this should continue. This should actually be at least 12 weeks and continue for longer for greater effect. Okay. And then whenever feasible, include Tai Chi. Tai Chi is a great exercise and is available in any public park in Malaysia as far as I can see. And then in long-term care, supervised exercises also recommended. Parkinson's disease, exercise is also recommended. And then after a stroke, you should also do exercise. After a hip fracture, you should also do exercise. If you have dementia, you should also do exercise. So there's no reason why you should not exercise. Okay, so that's easy. Hospitals and nursing homes I won't cover today, but there's a lot of recommendations pertaining to these areas because those are hotbeds for falls. Yeah, so sorry about the pun. Okay. And then cognition and falls. So if you ask the average family physician, do they actually screen for cognitive impairment in the older adults that they see? Usually they don't. But what we recommend based on this is if someone comes with you to you with a fall, you should also incorporate cognitive assessment as part of your multifactorial risk assessment. And then the other thing is that when you actually do your false intervention, you should also consider the older person's perspective and the caregiver's perspective, so you don't actually overburden them. So pertaining to somewhere like Malaysia, where we have very low resources for older people, you would find that going to clinics, going to hospitals is actually a big problem. The older person often needs assistance to go. So actually giving them multiple appointments for lots of investigations, they will not be able to comply and they start defaulting. So you need to actually get them to engage with you about what they can do and choose the best bang for your buck, if you like, if they're limited in their resources. But there are those who are very well supported, then you can go to town. Okay, falls and PD I won't cover today. And then falls and technology. There's so much we can do. But we do recommend the use of telehealth in combination with exercise training as part of prevention programs in the community. So those of you who are actually interested in telehealth, you might want to consider this. And then currently there's no support for wearable technology, such as fall detectors. There's also these, what do you call that? Airbags that you can wear, they can blow up when they sense you're falling, those sort of things. Currently, there's no evidence to support them. However, if you have wearables such as activity monitors as part of the exercise program, it actually seems to help them be more compliant, because you're actually monitoring whether they exercise or not, and they can see that they've got a bit of biofeedback, positive feedback. So lower middle income country like Malaysia, we hope that we won't be middle income for much longer, but we don't know. We'll never know. So we need to consider local contexts, definitely. Because a lot of times when I start talking, they ask me to go away because they say, where got this kind of resources where I work? So you need to consider what resources you have and make the most of what you have. So, but the thing with lower middle income countries is that we have far more people with cognitive impairment, far more people with obesity, particularly sarcopenic obesity, diabetes, poor footwear, environmental hazards. So we really need to pay attention to these risk factors of falls in our communities. And these are things we can manage. Yeah. And don't buy expensive things. Just use what is freely available and validated. And there are loads out there. Okay, so then multifactorial assessments, basically they work, and multifactorial intervention is what we use to manage high risk falls. Okay, so older adults falls perspective, I think I've covered that a bit, and this is also very important. So the title of today's talk is Getting Over a Fall. So falls actually have really bad negative consequences on the older person's psychology. So, so we should evaluate for fear of falling. And this is the tool that they recommend, the short FESI, and we have actually translated and validated it. And it's downloadable on the internet. Okay, so concerns about falls also has a lot of recommendations because it's a big, big thing. So there are a few more groups that I won't go through today, but we've also looked at dizziness, vision, hearing, and environmental hazards. We do have, as part of the service that we offer, home hazards assessment. So we can either do it physically if they live within kind of a reasonable distance of our center, or we can also do it virtually as well if you live somewhere else outside the KLPJ area. And there are loads of other things we need to look into: vitamin D, depression, frailty and falls, sarcopenia, delirium, pain, and urinary incontinence. So those have very little evidence, and we are trying to generate the evidence as we speak, but still lots of things to do in these areas. Okay, so in the last few minutes, I'm going to go through the thing that I hope you take away from today, which is our algorithm. Okay, so this looks nice, right? So I'm going to go through it in great detail. because I've saved a lot of time for this. Okay, so this is the World Falls Guidelines algorithm that we hope will be relevant to everyone in the world. Okay, so we welcome your feedback, because the idea is to actually then develop the second version of the World Falls Guidelines at some point in the near future. So low risk falls. So this is how we determine whether someone is at low risk of falls. So basically, everyone you encounter who is older, that's over the age of 60, whether it's when they come for the annual health visit or when you see them in clinic, you ask them if they have had a fall in the past 12 months. So if they say no, okay, then your goal is primary prevention. So if you take this opportunity to actually educate them about falls and tell them about the importance of physical activity and exercises, then we recommend that they are reassessed again for falls in the next year. So if you are a family physician, remember to ask all your patients whether they've had a fall, and then to repeat, to give them some advice on physical exercises and falls prevention, and then to repeat it the following year. So if they said yes, they have fallen, okay, then basically you then assess their falls severity. Okay, so yeah, can you see my mouse? Okay, so with the fall severity, basically, if they have had an injury, or if they had 2 or more falls, or if they look frail, or if they have been lying on the floor, they couldn't get up, or you suspect that they had loss of consciousness or syncope, which and those are unexplained falls, then they would be classified as high risk falls. If they have none of these, so they only need one of these to actually meet the criteria for high risk falls. If they have none of these, then we would call this intermediate risk. And basically, you want to test, you want to test a gait and balance, okay? And if the gait and balance is not abnormal, so you would then classify them as low risks, and then they're back to the education and falls prevention. So you're allowed to fall once a year. If you have no gait and balance problem, no worries. If they have yes, then they're intermediate risks, and then they actually should have secondary prevention with tailored exercises on that is actually focusing on the balance, gait, and strength. And this preferably should be administered by a physiotherapist, but we do understand that there are places where physiotherapists are not accessible. So any exercise is better than no exercises, and they should have education on falls prevention. So, but if they say yes to any of these risk factors, okay, then they're high risks, and they need what we call the multifactorial falls risk assessments. And at the moment, they are only accessible in a few centers in Malaysia, and it calls for you to refer them to a hospital. And very few hospitals actually offer these. So we actually have worked with the primary care physicians now, and there is now a service in KKKL where they actually are able to do multifactorial falls assessment in the community. And we hope that more and more clinic kesehatans and also private providers can take this up. But I showed you that picture of our center in section 19. We hope that that could be a beacon service. And we are now actually actively training primary care physicians to actually do this with in a not the whole complete way, but in a limited way in their own setting. And we have actually got a grant from the Selangor state government to do this for the Selangor state. Okay, so that's the end of my talk. So I'd like to thank everyone in this page that I could squeeze in to make for making all this work possible. that lots and lots of blood, sweat, and tears, but also lots of joy and success, and lots of publications, of course. Okay, and finally, I'd like to invite everyone to join us at My Falls, which is actually co-badged with the Malaysian Congress of Geriatric Medicine this year on the 3rd or 5th of August. And if you like to go somewhere else other than KL, well, this is actually in Setia City Convention Center in Shah Alam, because most people don't want to go in the middle of KL because of the LRT issues. And then, but if you fancy venturing over to Perth in November, there's the second World Congress on Falls and Postural Stability, which is co-badged with the Australian-New Zealand Fall Prevention Conference this year. So thank you very much.
The sorry, the statistics on death. So what is the numbers in Malaysia after a fall? How many of them will have mortality and we
You
saw the
try putting a fall as a cause of death for an older person. The police won't take it. Yeah. So they usually put sakit tua. Yeah. So we don't record falls as a cause of death for older people. Because if you're a younger person, it's perfectly acceptable, injury. Yeah, but for the older person, it doesn't seem to be recorded as a cause of death. So so we have to do it the other way around, So if you've fallen, we follow you up over 10 years to see how many people are no longer alive after a period of time. And as you can see, falls, it's not a diagnosis, isn't it? It's a symptom. So, and it's a herald that lots of things are wrong, which is why we go and look for these things that are wrong. And most people expect to find one cause, but what I'm telling you is you're going to find lots of causes. So and you need to put as many of them right as you can within your limited your resources and capability, and then hopefully that person will continue to enjoy a better quality of life and more freedom for longer.
so maybe I want you to guesstimate or estimate what is the percentage of acute death after a fall. So like patient with heart attack. So the chances of death within the first 30 days or 60 days or 1 year, we have a clear numbers. So
Yes.
in terms of fall, what is the rough numbers that you look at? After a fall, what's the chance of death within the hospitalization and within 1 month and 1 year?
Oh, okay. So you want a 30-day mortality after a fall. Yeah.
Yeah.
Unfortunately, we don't actually have that figure because not all falls actually present to medical to doctors. Yeah. So even if you try and pick it up in ED, they don't get recorded as falls. They get recorded as fractures. So it is actually, nobody actually think about, oh, how did this fracture happen? I should treat the cause, right, of the fracture. Otherwise, the fracture will happen again. Yeah, but so we are really a long way off in actually managing this properly. And I'm sure after the talk, a lot of if you were a family physician, you will say, "Oh, how am I going to do this? Because I haven't got the resources." So, but it's about the idea of starting things new, not doing what you're told, but starting something new to manage it. And yes, I wish one day that we could actually do this. What heart attacks are, after what's a 30-day, what's a 30-day mortality after a fall. We can do that, but we at the moment to even detect a fall is an impossibility because people don't actually record the fall.
And the reason why I'm so interested in fall because I have a few patients, a cardiac patient, who are very well and active. The fall is the one that kills them, and some of them pass away in the hospital, and some of them pass away within 30 days to 60 days.
Yes, I agree, and because it's likely that they have a cardiac fall, isn't it? And that's what I said earlier, that if you have a cardiac history or an abnormal ECG, then it is really a cardiac fall until proven otherwise, because it's so deadly. But it's also the only time where you can cure a fall with a single intervention. It's so rewarding. So, I saw this patient in emergency department. Nowadays, I'm sure you know what IED is like. we go down to, as a consultant physician on call. I have to go down to ED every morning to actually firefight to figure out where everybody is going, because the whole place is full. So I saw this poor uncle. He's so hungry because he lives far, far away, and his wife is not capable of bringing him food. And he stayed in ED all day yesterday, and they don't provide food in ED. So he's very miserable. And then he looked pretty well. And then what happened was he said, I fell in the kitchen. So, and it turned out that he's got a history of ischemic heart disease, and he had he just kind of couldn't remember what happened. So I looked at his ECG. He was a bit bradycardic, so high index of suspicion, and I sent him home because we get a private vendor to put in the ambulatory loop recorder. So we actually and asked the private provider to connect with him to put in his recording for 1 week. Then the private provider sent it to me, uh, the recordings, and we could find the pauses. So he then had the pacemaker put in the following week. So his first presentation to the hospital was for his pacemaker. Yeah. So after was never admitted, and that was so rewarding. Yeah, and he goes away very happy. Yeah, didn't even have to come into hospital, and we've saved life, haven't we?
So for the information of the audience, in the past we do holter, and the max that we can put in is 48 hours. But nowadays there's the vendor that provide a small gadget that you stick to the chest wall. It's not like a previous old-fashioned long holter, and it allows you to record ECG continuously for 7 days up to 14 days. It's a bit costly, but it helps us to capture many patients with some of these arrhythmias, especially pulses. Just now you mentioned about VT putting in an ICD. Actually, that's not very common. Most common is all this sick sinus syndrome, pulses in all the elderly patients, and it can be easily solved with a simple pacemaker, not the ICD. ICD is some of the rare patient. So I want to ask you, those patients who fall and they pass away, what are the main causes of their injury, and also what is the cause of their death after the fall?
We haven't got any way of clearly defining that at the moment, because most death registries most death records are inaccurate. So the ones we got were all sakit tua. So I don't know.
No,
Yeah.
we do have data in Malaysia. How about in overseas? So like no.
You'd be surprised how few people have published that data that we published. Yeah.
Oh,
Yeah, that's how we got it published, isn't it? You're like, how come nobody's looked at death? Yeah, because it's so difficult.
oh, then you have a gold mine of a publication then.
Yes.
So what is your theory then? Why do they what kind of major injury they have, and why do they die in such a short time after a fall? Yeah,
Uh,
even they were a fit man.
Remember, a fall is actually a herald of something not right. So it's a symptom, it's not a diagnosis. So something has led to the fall that could potentially endanger their life. And it could be anything. Could be COVID, could be flu, could be heart attack. It could be, people always look for a stroke. Sometimes it's a stroke, but very rarely, I think less than 1% of the time. Yeah. But a lot of times it's muscle weakness. So something has led to your muscles getting weak. So they could have underlying cancer, they could be a bit anemic. Or it could, and a lot of times it's the medications that they're taking. So that already heralds the fact that they are already not such healthy individuals. Yeah.
Okay, so maybe I want you to imagine putting yourself in the place of a clinician. I mean, the GP or even people like me as cardiologists. I spend longer time than the GP. I spend maybe about 15 to 30 minutes. The GP maybe 5 to 10 minutes. What are the things that they can do to first to screen, and second is to
Yes.
prevent? I mean,
So yeah,
in
so
such
the
a short time,
algorithm,
uh,
yeah, so the algorithm, yeah, it should be you actually ask the person whether they've fallen in the past 12 months. And then if they say no, then just basically give them a bit of advice about, you need to exercise regularly to stop yourself falling, and that's all they need to do. If they say yes, I've fallen, then you can do a timed up and go test. But what we advocate, if you can, because there's a waiting time outside, right? And normally your nurse will do their blood pressure and will do their blood pressure. And some GPs do a bit more. They measure the weight as well, BMI, and dip the urine. So while they're also doing that, can the nurse outside ask if they've fallen? And if they say yes, the nurse outside can already do the time up and go test. And then if it's abnormal and they don't have any of the high risk areas, then you can actually refer them straight to a physiotherapist. So work closely with the physiotherapist locally. So if they actually have any of those high risk criteria, then you should identify if a tertiary center, a hospital service, or if you're very lucky enough to be near KKKL, you should identify that center to send it with. But you should also consider starting an intervention, some sort of service of your own. Now that we've highlighted that there is actually a huge shortage of the kind of service out there.
So can you describe to us how do you do the time up and go
Okay,
in a clinic?
you just need a chair, and you just need a chair and a masking tape. So from the foot of the chair, from the front of the chair, the front feet of the chair, you measure 3 meters, mark with the masking tape, and then you get the older person to get up, walk to the masking tape, turn around and sit back down again. So the time between the bottom leaving the chair and bottom touching the chair again is called the tuck time. And 13.5 seconds and above, it's abnormal.
Okay. And you said starting the service in the GP clinic. So what kind of service that you expect the doctors to
Well, you
provide?
need to get trained. You need to get training. Yeah,
Oh,
you need to get training. Yeah. Without training, it's difficult. So we are actually actively offering training programs out there to actually train the GPs to do it. We don't advocate you do it yourself because it'll take a long time, take 2-3 hours. Where you got time to do 2-3 hours with a patient? Yeah, so you need to do it as a multidisciplinary team. So you need to engage assistance of your clinic nurse, whatever you have in your community, a physiotherapist, and then figure out how you can get yourself trained to actually provide a community-based falls prevention service.
I think this option is not not very easily done by most general practitioners.
No, we're
So
working. We're looking for people who are willing to work with us to actually develop this. Yeah.
how about some exercises that you can teach your patient to improve their strength and also balances? So do you have any tips
Yeah,
for
I
us?
say go do Tai Chi. If you haven't fallen, go do Tai Chi as a primary prevention. That's easiest. Yeah. But we actually have exercises that you can access very easily on YouTube. So we call them the Otago exercises that we actually share with our patients, the videos, and ask them to follow.
I know that some of this protocol is very long, So do you have one or two tips about uh, exercise that you can teach your patient in a
Yeah,
5 minutes consultation?
the Otago exercise. You don't have to teach, just share the video with them.
Oh, okay.
Yeah, play the video for them.
How long is this exercise, the Otago exercise?
Oh, you're supposed to do it at least 5 times a week, and then you're supposed to increase in intensity. So ideally, if they've already fallen, they shouldn't be trying to do this on their own. They should have it done by someone who's trained. Might not be a physiotherapist if those are limited in your area, but nowadays in Malaysia, physiotherapists are pretty accessible, I have to say. So it's preferably administered by a physiotherapist, and we're actively going out and training the physiotherapists to actually do this. So we're actually coming out with more and more resources that are available. That should be available soon. But what's available out there is already a video. You don't have to teach them anything. You just need to spend that 5 seconds to share a video link with them.
But if they come back to you and ask you how do you follow that? Because a lot of times some of these patients, and one is because of accessibility, because they said, I don't know any physiotherapy that can help me, and
Yes.
and I have no time or I have no transport to go to attend some of these things. Maybe you teach
Yes.
me. So what are the important facts in the point in this Otago training?
Oh, no, it's actually a series of exercises because it's supposed to challenge your gait and balance. Yeah. So yeah. So sorry, I know the cardiologist just wants a quick fix, and it's not going to be a quick fix. It's a
Okay.
multifactorial disorder. And
Uh,
why do we need to spend so much effort in fixing it? Because if not, the consequences are very severe.
okay. Now I understand why you're in geriatric, I'm in cardiology.
There's no magic pill.
Okay. Um, okay. So I think there's a question from the floor, which is very similar with what I asked you. They said, what is the best intervention to prevent falls? From which doctor? Yeah. So what is the best intervention to reduce falls?
Okay. Right. So basically, the best intervention is the intervention that the patient will do. Yep. So so it really, you need to consider the patient's capability, affordability, and their beliefs. So and it depends on the risk factors, isn't it? So if there's a clear gait and balance problem, and that's the only one that they have, then I would recommend that they actually have otago exercises. That is provided they've fallen in the first place. But if they've never fallen before, then everyone should exercise, preferably Tai Chi, at least 5 days a week, at least 30 minutes each time. And you need to have a blend of resistance as well as cardiovascular exercises. But sometimes the patient is not going to exercise. You know that. You and I look at each other and go, okay. Yeah. And they could be on multiple medications. So yes, do a medication review. It doesn't mean just stop the antihypertensive, because you'll anger the cardiologist if you do that. You should actually assess, look at the medication burden, look at potential side effects, and also and actually slowly deprescribe if possible. Yeah, but still consider blood pressure targets and cholesterol targets and all those things.
Okay. One last question for me. You keep saying about this Tai Chi. There are so many exercises. Why is Tai Chi so useful for falls? What is the reason for that?
Well, it's the only one that's been shown in a randomized control trial, multiple randomized control trials to be effective. And it's very special because it looks at balance as well as it seems to look at do balance as well as cardiovascular. So it's we call it multi-component exercise. And then they tend to do it in groups, isn't it? Yeah, so you go to the park, you do it together every morning. So the group thing is also, I'm sure, of benefit, because they are mutually supportive and they encourage each other. The exercise is slow pace enough so that it's very acceptable to most older individual, and so it seems to fit the bill at the moment, and for our culture there's no reason why not. Of course, I yearn for the day when we can look and see whether silat is also very useful for falls prevention, so wait for this space.
Thank you, Prof Tan. I think we come to the end of our webinar, and there's about 120 live audience.
Wow.
And,
Okay.
and I just want to ask you to give us the final, most important message that you want to give to all our audience here.
Just one thing, please ask your patient whether they have fallen in the past 12 months.
Okay. Okay, with that, I thank Prof Tan and also all the audience for attending our talk. And hopefully you can gain something from today, and make sure that you ask your patient about a history of fall, because a lot of times after they fall, they may not tell their doctors. They may tell their family, but not their doctors. And it's an important risk factor for future death and also other chronic diseases. With that, I thank all of you, and we will see you next time. Thank you, Maw Pin.
Bye. Thank
Bye.
you.